I'm a former 160th SOAR flight medic and current nurse practitioner. Today I'm teaching you cricothyroidotomy, the emergency surgical airway that saves lives when nothing else will.
A cricothyroidotomy is an emergency procedure used to secure an airway when standard methods, like intubation, fail. It involves creating an incision through the cricothyroid membrane, located between the thyroid and cricoid cartilage, to insert a breathing tube directly into the trachea. We also call this emergency surgical airway, or cric airway. Before learning how to do an improvised cric airway, it's crucial to learn step by step how combat medics do it. Assess the situation. Confirm the patient has a life-threatening airway obstruction or cannot be ventilated by other means. Ensure all other airway management techniques have been attempted and failed. First, gather equipment. Number 11, sterile scalpel, tracheostomy tube, or size 6.0, endotracheal tube, syringe, chlorhexidine or iodine, gloves, PPE, and suction position. The patient supine with the neck extended. Palpate the neck to locate the thyroid cartilage and cricoid cartilage. Find the soft depression between these cartilages, the cricothyroid membrane. Clean the area with antiseptic. Don sterile gloves and ensure all equipment is ready. Stabilize the thyroid cartilage with your non-dominant hand. Make a vertical skin incision, 1.5 to 2 cm over the cricothyroid membrane. Follow with a horizontal incision through the membrane, avoiding excessive depth. Use the scalpel handle or a hemostat to widen the opening. Insert a bougie, if available, to guide the airway tube. Place the tracheostomy or endotracheal tube into the opening, directing it downward into the trachea. Inflate the cuff, if applicable, and secure the tube. Attach a bag valve mask or ventilator. Verify placement by observing chest rise and fall, listening for bilateral breath sounds, checking for absence of gastric sounds, using capnography to confirm air exchange. Secure the tube with tape or a holder to prevent displacement. Continuously monitor the patient's oxygenation and ventilation. Hello, let me introduce myself. If in a hospital, we'd use a special kit with a scalpel, a hook, a dilator to open the hole, and a proper airway tube. Those tools are designed for one thing and one thing only. You don't have any of that. You have what you can find in an urban environment. At its core, you need two things: something to cut with and something for them to breathe through. Your cutting tool will be whatever you can get your hands on. Your everyday carry knife is the first choice. A box cutter from a back room, a craft knife from a desk, even a sharp multi-tool blade will work. It has to be sharp. Before you do anything, get it as clean as you can. Hand sanitizer or high-proof liquor is your best bet. If not, wiping it aggressively on the cleanest fabric you have is better than nothing. Yes, infection is a huge risk, but that's a problem for tomorrow. Now the tube, this is where you have to get creative by scavenging. You need a hollow tube that's strong enough to be pushed in and won't collapse. The classic improvised tool is the hollowed out barrel of a permanent marker or a sturdy metal pen. A cheap disposable pen might shatter. Look around. A rigid straw from a reusable tumbler, the casing of some piece of electronics. Take it apart. The size has to be big enough to move air, but small enough to fit. It's a terrible solution, but moving some air is infinitely better than moving none. This is the absolute raggedy edge of field medicine. This is it. The person is unconscious, they're turning blue, and you've already tried everything else. You get one shot. First, get them positioned. Lay them flat on their back. Ideally, you want their neck extended slightly, like they're sniffing the air, to make the landmarks stick out. A rolled up jacket under their shoulders can help. However, if you suspect a neck or spine injury, do not move their neck. Keep it in a neutral straight line. Now we follow the steps, deliberately, with purpose. Step 1, the laryngeal handshake, just like we practiced. Get on their side, Grip that thyroid cartilage with the thumb and middle finger of your non-dominant hand. Anchor it. Don't you dare let go until that tube is in. Use your index finger to find that soft spot one last time. Press in. Feel the membrane. You've got your target. Step 2. The vertical incision. Take your knife or cutting tool. Hold it like you mean business. You're going to make a vertical cut, about 1.5 inches long, straight down the midline, right over the membrane. You're feeling this cut goes through the skin and the fat underneath. It needs to be deep enough to expose the cartilage. And yes, there's going to be blood, maybe not a lot, but enough to block your view completely. At this moment, the procedure becomes 100% about feel. You can't see your landmarks anymore. You can only feel them. This is why that grip is so important. Step 3, the horizontal stab. Don't panic. Slide your non-dominant index finger into the cut you just made and find that membrane again between the two hard ridges. Feel for that dip. Once you're sure you have it, you're making your second more important cut. This is a horizontal stab, about 1/2 inch wide, right through the membrane itself. You're puncturing the windpipe. Aim the tip of your blade slightly down toward their feet to avoid hitting the vocal cords just above. Don't go deep. The trachea isn't very thick, and the esophagus is right behind it. Stab too deep, and you've created an even bigger disaster. You should feel a pop as the blade goes in. You might even hear a little puff of air. The airway is open, but a thin slit will just close back up. You need to make a real hole. You can use the handle of your knife or your finger. Stick it in the horizontal cut and twist or sweep to open it up. You need a hole big enough for your tube. Step 4, inserting the improvised tube. This is the moment of truth. Keep your finger in the hole as a guide. Don't lose your spot. Take your prepared marker barrel or other tube and slide it down right next to your finger into the hole in the trachea. Guide it downwards into the windpipe. Only push it in 1 inch or so. You don't want it going down so far it enters one lung, because then you're only breathing for half of them. Once it's in, you can take your finger out. Step 5, confirmation. Did it work? Put your ear to the tube. Can you feel air moving? Does their chest rise and fall? If the chest rises, you're in. If their stomach rises, you're in the esophagus. Pull it out and reinsert immediately. Once you know it's in the right place, that tube has to be held there. It will not stay by itself. Opening the airway isn't the end of the problem. It's the start of a new one. You just cut a hole in someone's neck with an improvised tool. The risk of bleeding and infection is massive. You have to keep that airway clear, holding that tube in place for what could be hours, making sure it doesn't fill with blood.
Remember the steps. Locate cricothyroid membrane, stabilize, incision, insert tube. This buys you minutes, maybe hours until help arrives. Practice identifying the anatomy now before you need it. This airway procedure is just one piece of combat medicine. For complete family preparedness, watch 5 Urban Survival Tools, link in the description. Thanks for watching. Suburban Prepper out.